cover the condensed PowerPoint today, just for the sake of time. So you guys will notice that you have a condensed PowerPoint for respiratory and cardiac, and then you have the full extended PowerPoint also. So the extended PowerPoint is going to be more so like a self-study. It's got a lot of videos and sound clips in there to help you with these cardiac and respiratory conditions. So hopefully that will help to fill in the gaps, but I at least made sure the big concepts are in this condensed one. So we'll have that and we'll have time for the whole Kahoot, hopefully. So this week we're starting with respiratory disorders. So the first thing we need to talk about is ventilation, and that is the process of breathing air into and out of our lungs. It's affected by our intercostal muscles, our diaphragms, ribs, brain, and chemoreceptors. So our respiratory tract develops before we're even born in a very orderly fashion. At 24 weeks, we start to have the alveolar cells are producing surfactant, which keeps those alveoli open and keeps them from collapsing once we're born. And then we're starting to notice those spontaneous respiratory movements in the fetus, but they're not actually doing gas exchange until they're born. It all is occurring through the placenta in utero. And then eventually, by the time they hit about 35 weeks gestation, we've reached that fetal maturity of our lungs. And in theory, should be able to survive outside of the uterus with minimal interventions. So we have our normal respiratory values. So we know our respiratory rate ranges in our pediatric population. We don't get to a normal adult rate until we're about 6 years old. And then our oxygen saturation should be above 90 in our pediatric population. And we know that having a high CO2 level that we see in chronic lung disease and that low O2 saturation can stimulate our brain to increase our respiratory rate. So we'll have this baseline tachypnea that is just our status quo with chronic lung disease patients. And those patients have receptors that are very tolerant to that high CO2 and low oxygen concentration, just because that's their normal. So if we give supplemental oxygen, we might actually decrease their respiratory effort because they're not used to having that much oxygen in their blood. So we can actually cause respiratory failure if we give too much supplemental oxygen to a patient with chronic lung disease. So when we're looking at respiratory disorders, we have a bunch of them. Nasopharyngitis is going to be 3 different conditions. So coryza, which is our common cold, which is what I had last week, which is why I sounded great. Allergic rhinitis, which is going to be your normal allergy symptoms. And then upper respiratory tract infections. It's important to remember that if a child has a fever with an upper respiratory tract infection, that we're giving small amounts of their favorite fluids frequently so that we're preventing dehydration. So whatever we can get them to take liquid-wise, we give them just so that they don't get dehydrated. And then when we're looking at acute pharyngitis, that's going to be our viral causes or strep. So anytime we have strep throat, we need to have prompt treatment to avoid those serious complications. So the big ones are going to be rheumatic fever and glomerular nephritis. You can see the other ones that are listed there as well that are complications of not treating that strep throat infection quickly. Sinusitis happens a lot in our pediatric population because our sinuses aren't fully developed until we're 18. So it's really easy for them to get infected. That'll require antimicrobial therapy. And then we have croup, and the fancy name for croup is laryngotracheobronchitis. So that is going to be that barking cough. that characteristic barking cough. They also have inspiratory stridor, and if they're crying or agitated, it will make their symptoms substantially worse. We treat them by providing humidity to relax their airways. So we can either use a cold water humidifier in the hospital. So you'll see we'll put them in a croup tent, which is just like this oxygen mist tent that has a lot of humidity in it. At home, you can see parents putting them in the bathroom and then running a really hot shower. So you get all the steam from the shower just filling the bathroom to help relax those airways, alleviate that stridor, and help reduce that cough. It's really important that we don't give opiates when we are dealing with croup, because that's going to decrease our respiratory drive. So the sedative effect of opiates will decrease our respiratory drive. Epiglottitis is swelling of the tissue above the vocal cords caused by H. influenza. It has a rapid onset, progresses really quickly, and is life-threatening if not treated. So this child is going to insist on sitting up and leaning forward. You're going to notice them holding their mouth open and constantly drooling. So that swelling prevents them from being able to swallow or cough. So that's why they're going to sit forward with their mouth open so that they can just let everything fall out of their mouth. It is crucial that we never examine the throat unless we have an alternative airway established. So if we place a tongue blade in the child's mouth, we can trigger a laryngospasm, and their airway will completely collapse on you. So most of the time we'll have to have either a tracheostomy in place or at least have them intubated before we even assess the throat. For bronchitis, we have this unproductive hacking cough that we can use cough suppressants before bedtime to help treat so that the child can sleep. And then we have bronchiolitis, which is a viral infection of our small airways. It occurs in our infants and children from like 6 months to 2 years. And the obstruction of the airway leads to atelectasis, so that collapsing of your alveoli can cause increased respiratory rate and heart rate. And that increased heart rate leads to irritability and dehydration. It's caused by respiratory syncytial virus, which is also one of the most common causes of viral pneumonia in infants. And the incubation period is about 4 days long. Any baby that comes back positive for RSV will need to be in droplet isolation precautions. And it's important that we use good hand hygiene so that we're not spreading RSV. It's really easy to spread. So we treat it with supplemental oxygen, IV hydration if they can't keep their respiratory rate under control to be able to eat. We use antiviral meds, and then we can give IVIG if we have to. For pneumonia, our symptoms are going to vary depending on what agent is causing the pneumonia. We can have a dry cough, fever, tachypnea, shallow respirations because of the pain associated with taking a deep breath. So if you've had pneumonia, you know it's really difficult to breathe. It just is extremely painful because the lungs are so irritated. So they're not going to want to take a deep breath. They're not going to want to cough. And that in turn just makes your pneumonia worse, which is very unfortunate. The child will be listless. They'll have a poor appetite. And if they have only one side that's affected with the pneumonia, they tend to lay on that affected side. So we're going to confirm it with a chest x-ray. You might also see elevated white blood cells. And then we might need to do cultures to figure out what our causative agent is. And then tonsillitis and adenoiditis, so your TNAs, you want to watch for frequent swallowing after surgery because that is a sign of bleeding at your surgery site. So that frequent swallowing, especially while they're sleeping, is an early sign of bleeding. And we want to make sure that we don't give them milk or any milk products, because that can cause coat the throat and cause the child to want to clear their throat and irritate that operative site. Same thing, we're not going to let them have red popsicles or red juice because we don't want to mask bleeding. So no milk, no red things until we're sure that the surgical site has healed. For asthma, it's going to be just like adult asthma. We've got an obstruction that's going to be most severe on expiration. You can have acute episodes where they're coughing, wheezing, having difficulty breathing. Watch for signs of air hunger. So those nostrils flaring, using our accessory muscles, orthopnea. And then status asthmaticus is going to be just like status epilepticus. So continued severe respiratory distress that doesn't respond to medication. So just like status epilepticus is. And that is also going to be a medical emergency. When we're talking about cystic fibrosis, it is a multi-system disease in which thick viscid secretions affect our respiratory system, digestive system, our skin, reproductive system. So our respiratory system gets obstructed by those really thick secretions. And then those same secretions prevent our digestive enzymes from flowing into our GI tract, which means we can't absorb the nutrients in our food very well. So we'll have bulky, foul-smelling stools that are frothy because of the undigested fat content. And then our skin will lose electrolytes through our sweat. So that can cause that salty skin surface that you hear about with cystic fibrosis patients. So that's actually one of the diagnostic tests that we do, is we do a sweat chloride test where we make them sweat. And then we test that sweat and you will see a high chloride content or high salt content in their sweat. It can also cause infertility due to secretions that decrease the motility of the sperm and can thicken the cervical mucus. So parents will need a lot of education, especially nutritional counseling. So their diet should be high in sodium and protein so that we're increasing their ability to have an adequate source of energy and then replacing that sodium that they're losing through their sweat. They're going to need medications. We're going to have to give them pancreatic enzymes at meals. We're going to teach them things like postural drainage to help with those secretions. Infection prevention is going to be key. Even a simple cold for a cystic fibrosis patient is life-threatening. They're going to need lots of rest periods. If you think about trying to do a vigorous activity while breathing through a straw, that's about what everyday life is for them. So they have a lot of trouble breathing, can't do a lot of activity. They need frequent rest periods. They're going to have lots of medical appointments, therapies, follow-up appointments, and then they will also need emotional support for dealing with having a chronic condition. Bronchopulmonary dysplasia is fibrosis or thickening of the alveolar walls and bronchiolar epithelium. So we see this most often in our premature infants, especially when they have been on mechanical ventilation for an extended period of time. So having that constant beating on their lungs, trying to keep them alive, causes barotrauma, and then the body compensates by making this fibrosis or thickening to help combat that barotrauma. So we see it a lot in our preemies, especially if they've been on a ventilator for a long time. Lastly, sudden infant death syndrome, or SIDS, is going to be a sudden, unexpected death of an apparently healthy infant between 2 weeks and 1 year of age. And it peaks between 2 to 4 months when they're first starting to roll over. So you can see that they can roll over, not necessarily be able to lift their head completely to clear their airway. And that is when you're at most risk for developing SIDS. Questions about respiratory? Pretty straightforward.
Yeah, but I have a question. Is it it's very uncommon for a child to die at 3 from SIDS?
Um, I would say it's less common. I'm not gonna say it doesn't happen. I would think there was an underlying condition by then. Um, but yeah, if there's no explanation, then a lot of times they will call it SIDS, even in an older child.
Okay, just curious.
Okay, cardiovascular disorders. This is the other half of our lecture. So our cardiovascular system is the first system to function in intrauterine life. So the very first thing that develops for us. And we'll learn there's lots of things that can potentially go wrong with that. So congenital heart disease can be caused either by genetic, maternal, or environmental factors. It's not a problem in utero because we have that fetal maternal circulation that's taking over. So a lot of these disorders we don't realize until the child's born. At birth, the infant circulatory system has to take over and provide for the oxygen needs. So that's where we see a lot of the symptoms. So we have two categories of congenital heart disease. We have cyanotic, which are diseases that make you turn blue, and acyanotic are diseases that you stay pink. So we can categorize the defects into what they do to your blood flow. So if they increase your pulmonary blood flow, you probably have an atrial septal defect, which is going to be an abnormal opening between the right and left upper chambers, so your atria. You can have a ventricular septal defect, which is the same thing, but just your lower chambers, so your ventricles. And then you can have a PDA, which is a patent ductus arteriosus, and that is part of fetal circulation from the pulmonary artery to the aorta that didn't close after birth like it was supposed to. So we can treat those with either indomethacin or ibuprofen. We are starting to use Tylenol as well for treating those. And if we can't treat a PDA with medication, there are surgical options to correct that if it doesn't respond. We have obstruction of our blood flow altogether. So that's going to be our coarctation of our aorta. And we'll talk about that in detail later. Decreasing our pulmonary blood flow is going to be tetralogy of Fallot. We'll talk about that at length. And then mixed blood flow is going to be our hypoplastic left heart syndrome and our truncus arteriosus. And when we're talking about shunting, it refers to the flow of blood through an abnormal opening between two vessels of the heart. So you can have shunting between your ASD, your VSD, or you can have shunting in your PDA. And the blood is always going to flow from areas of high pressure to an area of low pressure. So it's going to take the path of least resistance. And you'll see that a lot in the extended PowerPoint when they do the graphics in the videos. They'll show you different shunts that can happen. And that path of least resistance. So overall, when we're caring for patients with congenital heart disease, we'll see increased pulse respirations, we'll see retarded growth, dyspnea and orthopnea, fatigue, and they're at risk for upper respiratory infections, especially with those increased pulmonary blood flow disorders. We encourage them to avoid competitive sports because of the fatigue and strain it puts on your heart and your lungs. We also need to provide nutritional guidance. They're going to need high calorie meals, but they're going to have to be small and frequent to avoid that fatigue. So we really have to maximize our calories in as little as possible for these patients. And they also need to be careful of high altitudes and cold environments because that can put stress on your respiratory system. So when we're looking at our coarctation of our aorta, so that is going to be our kinking or our restrictive disorder. And that is going to be a narrowing or constriction of our aortic arch. And we diagnose that with an aortogram. You can notice clinically higher blood pressures in your upper extremities and decreased blood pressures in your lower extremities because your lower extremities aren't getting as much blood because they're on the other end of that kink. So if left untreated, you can end up with hypertension, congestive heart failure, and infective endocarditis. So our tetralogy of Fallot is one of those disorders that decreases our pulmonary blood flow, and it is a combination of 4 defects. So you have stenosis or narrowing of the pulmonary artery, which is going to decrease the blood flow that goes to the lungs. You have hypertrophy of the right ventricle, where the right ventricle becomes enlarged because it has to work harder to pump the blood through that narrow pulmonary artery. And then you have dextroposition of the aorta, where the aorta becomes displaced to the right and blood from both ventricles is going to go into the aorta. We have these paroxysmal hypercyanotic episodes, which we call TET spells. So they typically occur during the first 2 years of life. And it's this spontaneous cyanosis. So all of a sudden, the patient will turn blue, they'll be in respiratory distress, they'll be weak, and they can pass out. They can last up to a couple hours, and they have a very similar post-ictal state. So just like a seizure where you get drowsy and confused afterwards, these patients are really lethargic and sleepy after a TET spell. So kind of similar. When we have a patient having a TET spell, we want to make sure we shove their knees up into their chest. And that will help to use the abdominal pressure to force the blood to flow out of their heart and help get more oxygenated blood into their circulation. So for an infant, you can just tuck their knees up to their chest. For an older child, you might notice that they will self-correct and all of a sudden they will just squat. And that squatting position will help to push the blood out of the heart and get more oxygen to the circulation. When we're looking at congestive heart failure, we can have it in our infants. We might notice things like tachycardia at rest, fatigue while they're eating, sweating around their scalp and forehead. Sweating in an infant is never a normal sign. They'll have dyspnea, and then a sudden weight gain is always a telltale sign. So when we're doing our nursing care, we want to make sure that we're nice and organized so that we're giving them extended periods of undisturbed rest to let them recover. If they wake up early, then we go ahead and feed them early. We don't wait until their scheduled time. We want to maximize that time that they're awake. They might eat a lot more often because they don't have the stamina to take in a full volume. So they might be a kid that eats every 2 hours instead of every 3 to 4. We can give them supplemental oxygen to relieve their dyspnea, and then we'll give medications as prescribed after we check for safety. When we're looking for signs of proper medication administration, a consistent weight can be a sign that parents are following that regimen and that our doses are correct. So if we notice a sudden weight gain or sudden weight loss, then we might suspect non-compliance with our home therapies. But if we see that consistent, steady weight, we know our doses are great and the patient's getting them regularly. We're going to do accurate INOs and then those daily weights so that we can assess the our therapies. When we're talking about rheumatic fever, it is an autoimmune disease that occurs as a complication of our untreated strep infection. So it involves our joints, our heart, our nervous system, skin, and subcutaneous tissues. We treat with penicillin for those strep infections, and that's going to prevent the permanent heart damage caused by rheumatic fever. They'll be on antimicrobial therapy initially, and then on chemoprophylaxis every month for a minimum of 5 years. And that's to make sure that we don't get a recurrence of the infection and possibly cause that rheumatic fever. They're going to need lots of rest periods. We're going to have to look at pain relief. So the joint swelling and pain, we can use anti-inflammatory agents, steroids, and aspirin. And then one of the potential side effects is cardiac failure. So being ready to manage that. In the extended PowerPoint, you will see the major criteria and the minor criteria for rheumatic fever and the mnemonic to remember those. And that is in your book as well. Systemic hypertension can happen in our pediatric population as well. It's typically due to a poor diet and lack of exercise. So we do nutritional counseling, just like we do for our adults. So we recommend the DASH diet, which is going to be low-fat milk products, lots of fruits and veggies, fish, poultry, low-sodium products, no refined foods, no processed foods. We're going to encourage activity so that we can bring our weight down, and then counsel our adolescents on adverse effects of drug, alcohol, and tobacco. And then in the event that we have secondary hypertension, then we will have to figure out what the underlying disease is that's causing that elevated blood pressure. And that's what we will target our treatment towards. And then the last thing we have to talk about is Kawasaki's disease. So it's an illness with an unknown cause that typically occurs after a viral infection. We diagnose it based on the clinical signs and symptoms. We don't have any labs that we can do that say we have Kawasaki's disease. It causes inflammation of the vessels in the cardiovascular system, which is going to weaken the walls of those vessels and can cause aneurysms, so that abnormal dilation of the blood vessel. And those can cause blood clots to form, which can be life-threatening. So we really have to be on top of this. The signs and symptoms that we see are those bright red eyes, a strawberry tongue, peeling of skin and rashes, and then cracked lips. So those 4 pictures along the bottom are telltale signs of Kawasaki's disease. We treat it by giving IVIG, and if we give it early, we can prevent the development of the coronary artery pathology. They will be on aspirin for its anti-clotting properties. And then if they have aneurysms, we might have to step it up and place them on warfarin or Coumadin so that we're keeping the blood thin and not introducing any clots that could make one of those aneurysms burst. What questions do you guys have over the cardiac disorders? Pretty quick and painless there. Like I said, the extended PowerPoint has a lot more in it for you guys. It's got videos with graphics of all of the different types of cardiac conditions, and then it's got some sound clips for you of some of the respiratory disorders. So that will hopefully be very helpful as you're studying and getting used to all these disorders. I will get our Kahoot logged in here and give you guys some time to get logged in. Okay, do we have everybody? We'll stick our pin in our chat for anybody that needs to join us later. Otherwise, you can just follow along on my screen. Here we go. So acute coryza is another name for our common cold. Signs and symptoms of congenital heart disease are going to be that increased pulse, that delayed growth. They're going to be at increased risk of upper respiratory infections, have that tachypnea, dyspnea and orthopnea, and fatigue. So all of them are signs of congenital heart disease. Oh, sorry, guys. So oxygen is going to be carried to the body by erythrocytes or our red blood cells. Patients with RSV are going to require droplet precautions. So we spread RSV by either coming into contact with a surface that somebody has sneezed on, coughed on, or them coughing directly into your face. So gown, glove, mask, goggles, the whole shebang. Our fancy name for croup is laryngotracheobronchitis. The term for the collapse of an alveoli is going to be atelectasis. So when they collapse and they can't open back up, that is atelectasis. And we can treat that by either giving artificial surfactant or we can use CPAP to help keep those alveoli from being able to collapse. Tachypnea is increased respiration. So we know that tachy is fast and the pnea is regulated to our respiratory system. Children with cystic fibrosis take pancreatic enzymes to help them digest their food. So we help to provide the nutrients that our secretions are blocking. And we typically give those with applesauce in our pediatric population. So when we have a fever with an upper respiratory infection, the most important thing is making sure we keep them hydrated. So giving them small amounts of their favorite fluids.
And that was hard to read.
Yeah. Then we can also treat with Tylenol or ibuprofen if needed. But yep, your favorite fluids are going to be your most important. Asthma is our leading cause of school absenteeism, increased doctor visits, and increased hospitalizations in our pediatric population. So all three of those. So if you think about it, if they're having an asthma attack or before school, it might cause them to miss the whole day. They might have to go home early because of an asthma attack. And then doctor visits for medication adjustments, and then hospitalizations for any prolonged asthma attacks. The virus that causes pneumonia in infants is going to be that respiratory syncytial virus, or RSV. The defects that cause increased pulmonary blood flow are going to be our ASD, VSD, and PDA. So those holes in between the chambers and that extra vessel are going to create more blood going to the lungs. Swallowing frequently after a TNA indicates bleeding at that surgical site. So we might have to go in and cauterize some bleeders that might have happened. Signs and symptoms of respiratory distress. So abnormal breath sounds, that increased respiratory rate, and confusion. You will actually see tachycardia rather than bradycardia with respiratory distress. meant to fix that. We want to keep our children's oxygen saturations above 90. How does a child with CF get it if neither parent has it? That means that both parents are carriers of the CF gene. And that happened to be, the child got a copy from each parent. So that's how they ended up with cystic fibrosis. So the parents were carriers. They only have one abnormal gene, but the baby just happened to get both copies. So they have two abnormal genes. So a child with asthma that's having difficulty breathing and fluid loss, we want to give them room temperature water. Carbonated beverages are just going to dehydrate us. And then cold beverages are going to be more uncomfortable in their airways. And we definitely want to avoid milk anytime we have difficulty breathing. It's going to cause us to want to cough more.
Wait, did you say that carbonated drinks can get you dehydrated?
Yes.
Oh, I didn't know that.
Yeah. Yep. Typically, your carbonated beverages are going to be your sodas and things like that. So those are going to be poor choices. Or 72 hours after a smoke inhalation injury are when they're at greatest risk for pulmonary edema. So sometimes you can see this delayed onset of the swelling in the lungs in result of an inhalation injury. So if we do 4-point extremity blood pressures on a child with a cohort, that's one of those kinking disorders. So we expect to see high pressure in the upper extremities where that nice wide opening is, and then low pressure in the legs where it's got to go past that kink. So you're going to have decreased blood flow to your lower extremities. Children with cystic fibrosis need high sodium and high protein. So good source of energy. And then we have to replace all that sodium that they're losing through their sweat. Blood flow between the vessels of the heart is a shunt. So it can be either through that abnormal opening between the chambers or through an abnormal vessel. Either one. You can have it gone all to the left, all to the right, or you can have a mixed shunt where it goes back and forth. Your atria are your top chambers because your A points up. So that's going to be an abnormal opening between the upper chambers. Your V points down, so that's your lower chambers. So a VSD would be an abnormal opening in the lower chambers. So children having a TET spell are going to drop into that squatting position because it's going to use the pressure in the abdominal cavity to increase the return of your venous blood back to your heart so that it can get oxygenated and pump out. Tiring out during feedings is going to be one of those telltale signs of congenital heart disease or those congenital heart defects. So they don't have enough stamina because of this defect to complete a full feeding. So you'll see they'll take small volumes and they wake up a lot. That abnormal opening between your ventricles causes the blood to go the path of least resistance. So it's going to go left to right, which is going to cause an increase in pulmonary blood flow. but they're gonna stay pink because they've got that oxygen in there. An echocardiogram is going to be that ultrasound that we use to look at that structure of the heart. Barium swallow is going to be GI tract. An electrocardiogram or is going to look at the rhythm, and then an EEG is going to look at the electrical activity of the brain. This is part of the Jones criteria. We remember that rheumatic fever can cause inflammation of the heart, can also cause inflammation of the joints, and then chorea as well. When we have rheumatic fever, we're going to be on penicillin for 5 whole years to make sure that that infection never comes back. H influenza causes epiglottitis, which is going to be that swelling of our vocal cords, and that is a life-threatening illness. That's where we have to have the tracheostomy or the advanced airway before we can assess the throat. So this is the second half to that. We have to have emergency intubation for epiglottitis so that we don't cause a laryngospasm and cause them to lose their airway. Primary hypertension is treated with a DASH diet, so diet modification and encouraging activity. So an aortogram is going to diagnose that coarctation. It's going to find that kink in the aorta. So all of those are potential signs of congestive heart failure. So we know we want to watch our weight. If we notice tachycardia outside of normal activity, that would be abnormal, difficulty breathing, and then that fatigue when you're eating. Almost there, guys. So HDL and LDL. HDL you want high because it's a good cholesterol, so it's going to reduce your risk of plaque buildup. LDL you want low because it's going to increase your risk. Hyperlipidemia is going to be too much fat in our blood. Hypoplastic left heart syndrome is going to be underdevelopment of our left ventricle. So we have that really tiny left ventricle with our heart. So let's see who our winner is. Hi.